Welcome to Gamble with Brandl. Today we have a 40-year-old patient with type 2 diabetes on metformin that comes in for a follow-up examination. Patient has a history of genitourinary infections and also would like to have help to lose weight. And the A1C is 7.6, and you're going to recommend a drug with which of the following mechanism of action? We have here a couple of options. So the patient has an A1C of 7.6. That's a bit above goal, so you would like to see something below 7. So it would make sense to add another medication. Which one should we add? We have a history of genitourinary infection and also wants to have something that helps the patient lose weight. So let's go through this option and see what would make most sense to add. So a GLP-1 agonist is a drug like exenatide or liraglutide. And GLP-1, we found it a lot of different places. The GLP-1 receptor in the brain, where it's going to decrease appetite. In the stomach, where it's going to decrease gastric emptying. And then also on the pancreatic beta cell, we have GLP-1 receptors that help us to release insulin, but it's in a glucose-dependent manner, so it's not just be kicked out independent of the meal. It just helps us to release it more easier because GLP-1 acts at the GLP-1 receptor, GS-coupled, more cyclic AMP, phosphorylation of the calcium channel, and calcium triggers exocytosis. So if you're thinking about a drug losing weight, yes, definitively, that would be a good choice. So let's keep that in mind. So there's nothing against it. It's high efficacy drug, so we could even decrease the A1C more than we actually need. The next drug is a SGLT2 inhibitor. So this drug class, they add all in gliflozin. Keep the glucose flowing. So this is gliflozin that just prevent the absorption of glucose in the kidney. So their target is the kidney, this transporter, the SGLT transporter that takes back glucose. We inhibit it and the glucose is just flowing out. And so we're going to lose glucose. That's going to help us with the glucose levels. In diabetes, also we pee out basically calories. That's helping also with weight. So this is also a drug that will help with weight. So it's going to increase or facilitate weight loss. So that's also good. However, we are having glucose in our urine, and who's gonna love that? All yeast, fungi, bacteria, they love to have the glucose around. So this drug increases the risk for genitourinary infections. So in that way, I mean, as a patient has a history of that, would exclude this drug. Now the next one are our famous sulfonylureas and non-sulfonylureas that just close the potassium channel and therefore you just kick out extra insulin. They are very efficacious, so we could definitively lower the A1C, but because we just kick out insulin without being dependent on how much glucose we have in our body, we have a high risk of hypoglycemia, so that's a major problem of this drug class. And also because we just kick out insulin. Insulin is a fat-storing hormone, so we're going to gain weight. The moment we're just kicking out insulin, these lead to weight gain. And the other problem, we have hypoglycemia with this drug. And then the PPR gamma agonist, PPR gamma is a nuclear receptor and does a lot of different things on a transcriptional level. And they all end in glitazones. These are the glitazones, the TCDs. They do a lot of different things. They also lead to edema, which also facilitates weight gain. There may be different things as well. We're definitely gonna gain weight. how the weight gain is explained via direct effects of PPR gamma, but also via the edema. So for this particular patient, not consider that because it leads to rather weight gain. So we're going to stick with our GLP-1 agonists, things like exenatide or liraglutide for this particular patient.